Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm starting a new series on rheumatoid arthritis. Rheumatoid arthritis is a very serious problem. Across the world, there are 140 million people who are afflicted with rheumatoid arthritis. In this country, there are 2.1 million Americans that are afflicted with rheumatoid arthritis. Rheumatoid arthritis is about 2-3 times more common in women than men, and it affects people from all ethnic background. So it is basically the mother of all the inflammatory arthritis that exists across the world. And as the series develops, you will know a whole lot about all these things, why rheumatoid arthritis is so serious. And it affects several joints. And the joint it affects the most, of course, are the feet, the ankles, the hands, the fingers, the elbows, the wrists, shoulders, hip, neck, lumbar spine, and thoracic spine. All these different joints are afflicted by rheumatoid arthritis. It is a systemic disease as well, and it affects a lot of other organs, including the heart, the lung, the brain, the blood system, the kidney, the skin, and neurological system. So it is basically there's no organ in the human body that doesn't get afflicted to one degree or another by rheumatoid arthritis. It's chronic, and if a person remains without treatment, the deformities in the joints are really, really very bad, especially the hand. The hands are so deformed the person can barely hold a spoon to feed him or herself. It's that bad. Several individuals had to give up their own professions that require the use of the hand because of the deformities. So, and the symptoms, of course, are pain, tenderness, swelling, and not only the swelling, muscle spasm. The pain can be very severe. And then sometimes they develop effusion in different joints, such as the knees or the ankle or the elbows. They can develop effusions, and they're similar to what I spoke about last week that is seen in osteoarthritis. The difference is that this is an autoimmune disease. What do I mean by autoimmune? It is disease whereby the body itself reacts against itself. To this day, no one has been able to figure out what is the real cause of rheumatoid arthritis. They've done all the research you could possibly think of. They have not been able to pin down what is the exact cause of it. Suffice it to say, it is an autoimmune disease. The body reacts against itself in the joints, and the joint then become inflamed, and the inflammation lead to the deformity chronically in the joint that are affected, resulting in severe deformities and pain to one degree or another. What is even more complicating with this is that it can be associated with other autoimmune disease as well. So if one has rheumatoid arthritis, then one is required not only to diagnose the rheumatoid arthritis, which we will in time talk about, we also required to evaluate for a series of other diseases. Some of them are rheumatological in nature, some of them are not. An example, person with rheumatoid arthritis may present first with hemolytic anemia, whereby the red blood cells are hemolyzing. Or the person may present first with chronic leukocytosis, low white blood cell count. Or the person may present with low platelet count, or pancytopenia, meaning all 3 cell lines in the circulations are low in quantity. So that could be one presentation. So one is begin to evaluate why all these cells are low, then one can stumble on rheumatoid arthritis. Sometimes those things present first before the pain begins. And also, as I said, the list of other diseases that are of a rheumatological nature that can be associated with rheumatoid arthritis is extremely long. Dermatomyositis, polymyositis, scleroderma, lupus, on and on and on, psoriasis, on and on and on. So once you have the suspicion that the person may have rheumatoid arthritis, then you have a lot of work to do. A lot of work to do, because sometime in the beginning of the processes, those other things are much more serious in an acute setting than the rheumatoid arthritis itself, because the rheumatoid arthritis is chronic. It's a chronic disease. There's really no cure. There are treatments, all sorts of treatment, medical treatment, rheumatological treatment, surgical treatment, so on and so forth for rheumatoid arthritis, but there's no cure. So once you see that the individual you suspect they have rheumatoid arthritis, then you have to evaluate for these other conditions. If their other conditions are rheumatological in nature, that is called mixed connective tissue diseases, mixed connective tissue diseases, if they are rheumatological in nature. If they're not, and then they're present, then you evaluate them. That's called overlap syndrome, okay? Overlap syndrome. You have to understand, once an individual has one autoimmune disease, he or she, if he or she lives long enough, may wind up with 2 or 3 more during lifetime. So you must always be on the lookout while you are treating the one that you diagnose. You must constantly evaluating the patient for others that might show up in the process of you treating the rheumatoid arthritis. It's a very, very serious disease, very common, 140 million people across the world. And sometimes the patient presents first with a cardiac problem. Yeah, cardiomyopathy, myositis. Myositis means the muscles can be swollen, and that may be the first indicator that the patient may in fact have rheumatoid arthritis, because they present with muscle weakness, pain in the muscle, with very high CPKs, and then you're trying to figure out why is the patient's CPK, total CPK, so high. And then as you begin the evaluation, you find, my goodness, this is part of a rheumatological problem. Or the patient may present severely anemic. And then you find out, well, there are different types of anemia, okay? Rheumatoid arthritis is associated with more than one type of anemias, not just hemolytic anemia. That's only one part of it. That may be a second autoimmune disease. But if one has rheumatoid arthritis and one lives long enough, you're going to have anemia of chronic inflammatory diseases. This is a different form of anemia. It is anemia, but it's not hemolytic anemia. This particular anemia exists because rheumatoid arthritis is also an inflammatory disease. It is the inflammation that will ultimately cause the bone to be damaged and deformed, etc. So once you have the inflammatory processes going on, a person cannot use iron. Either the iron that you're eating, or the iron you're taking by mouth, whatever, you just cannot use it. You say, well, how come? Well, the inflammation. All of us have in our system transferrin receptors. The transferrin receptors are the material that grab onto iron molecule to take it into the bone marrow so that it can be incorporated into baby red blood cells, so we can make regular mature red blood cells, so as to be able to have enough hemoglobin to carry oxygen to perfuse the body. That's the mechanism. However, when you have a chronic inflammatory disease such as rheumatoid arthritis, the transferrin protein cannot do the job. They're circulating. In fact, we could test for them. The level is very high in the bloodstream, but they can't work. They're not doing the job because the inflammation blocks the ability of the transferrin receptor to grab onto the iron. Can't do it, so there's a block. Let's say this is right here. The iron is over here. The transferrin receptors are over here. You got to jump over this, got to cross over in order for the transferrin receptor to grab onto the iron. There's a block right here, and this is the inflammatory processes that's causing the block. So therefore the iron, it piles up over here. So here it is, you have rheumatoid arthritis, which is a rheumatological process that's causing the bone to be destroyed, to be inflamed. On top of that, you will have a second problem. The second problem, of course, is the iron that is piling up. So that's a second serious problem, because once the iron is piling up, wherever it is piling up, it must by itself degrade. Away from anything else, it must degrade. As the iron begins to degrade, it's releasing free radical. The iron can't just sit there. It's going to sit there, but it must degrade. That's just the way nature is. As it's degrading, it's releasing free radical. The free radical then creating an inflammatory process. We're already starting out with a severe inflammatory process that's involved in rheumatoid arthritis, but now we have a second inflammatory process going on, namely the effect of the iron that are piling up. There's no way you can't have rheumatoid arthritis, don't be anemic. You may not be hemolyzing, but you're going to have another form of anemia. This is normocytic anemia. Normocytic, normochromic, we call it anemia because you can't use the iron. It's piling up. You're anemic, but and in fact, you are iron deficient. How about that? You can say, well, Val, how can you say somebody has a ferritin of 2,000? The normal is a man is 320 and a woman is, 199 or 220 or so, 199, I think. And you're going to say the person is iron deficient. Yes, you are, because you can't use the iron. So what's the point? So therefore, you are iron deficient. You have a pileup of iron, but you're still iron deficient because you can't use the iron. What's the point of having the iron sitting on the other side of the block? It's not doing anything to help you. If anything, it's hurting you, but you are in fact iron deficient, severely iron deficient. And not only that you're severely iron deficient, I can explain to you where the matter is even worse. Because we have another system called the oxygen dissociation curve. I know I'm being very academic, but I'm not going to make excuse for that, because that's who I am. The oxygen dissociation curve must be shifted to the right in order for it to grab onto, for us to be able to deliver oxygen to the body. It has to grab. But when you have this inflammatory process going there, the oxygen dissociation curve is shifted to the left. That's right. So therefore, you are hypoxic no matter what. You could take all the oxygen you want, you're still hypoxic because there is not enough good red blood cell. The oxygen won't do you any good if you don't have hemoglobin for it to grab onto to deliver to the tissue. So therefore, the oxygen dissociation curve is shifted to the left. It's going to stay to the left until you resolve that problem, until you find somewhere, and there is a way, there are ways to resolve the problem, to allow a situation that will allow the receptors to grab onto that iron, the transferrin receptors. You are severely anemic. I don't care how much iron you have piling up there, you're still iron deficient. Okay? You may have iron overload, and yet you're iron deficient at the same time because you can't use it. Okay? I mean, true iron deficiency is bad, but it could be from bleeding most of the time. That's why people lose iron, because they're bleeding one place or another. But in this case, you have yourself a double problem. You got this very serious inflammatory disease, namely rheumatoid arthritis, and you have iron overload, which then causing you to be damaging different organs wherever the irons are piled up, because the irons are piled up everywhere. Everywhere that the rheumatoid arthritis is causing damage to occur, the iron that's piling up is also causing damage to occur. You have a double whammy. So you have to understand these mechanisms, because if you don't understand these mechanisms, there's no way you're going to be able to help to treat this patient, because this patient needs a lot of help. And this patient with rheumatoid arthritis needs help from different specialists, the rheumatologist, the orthopedic doctor, the cardiologist, the hematologist like myself, the internist. You understand that you need all these specialists to help you take care of this patient, because there's no way you're going to have rheumatoid arthritis and don't subsequently need the help from an orthopedic doctor, because no matter what it is that a rheumatologist is doing, they're doing a great job. The joint, ultimately, different joint is going to need help. Sometimes they have to be replaced by the orthopedic doctor. When the iron, first of all, when the rheumatological problem is causing inflammation to occur in the wall of the heart, muscles of the heart, that inflammatory processes is going to cause a lot of problem with the heart, including all sorts of arrhythmias, all sorts of arrhythmias of different types, congestive heart failure, because you're going to develop ultimately cardiomyopathy because of the heart becomes enlarged, so the piled up of iron and inflammation that's in it. And then you wind up with an enlarged heart, which will ultimately cause you to have heart failure, and so on and so forth. And of course, yes, you could also have a high incidence of having coronary artery disease, because that's one of the main causes of coronary artery disease, the inflammation that occurs. It doesn't matter how it occurs. You could have rotten teeth in your mouth. That's not being cared for. That can cause you to have an acute heart attack, because as the material dislodges from the mouth, it gets taken away by the bloodstream. Some of it is going to pile up in the wall of the coronary arteries. You have an occlusion to occur right there, okay, and so on and so forth. So this is a very serious disease, rheumatoid arthritis, very serious. Nobody knows the cause of it. And it affects all ethnic groups. But women are two to three times more likely to develop it than men. Well, what are the symptoms? Well, the symptoms are, I mentioned to you all the different joints that are affected. In fact, there's no joint in the body that's not affected that cannot be affected by rheumatoid arthritis. Well, the joint is going to be, there's going to be swelling. There's going to be tenderness. There's going to be pain, okay, acutely. And then chronically, there will be destruction and deformity first and then destruction of different joints. Wherever the bone is, could be in your back, could be on your hip, could be on your knees, your ankle, your feet, your elbows, your shoulders, your fingers. I mean, I have pictures here that I will ultimately put on the screen to show you as the series goes on, the deformity, what the deformed fingers actually look like. Not very pleasant looking. Okay, so you will eventually get to see them. I'm not going to show them to you in this segment, but that's this is deformed fingers, okay? This is what the normal finger look like. Look at the deformed fingers. This is, and you cannot do it because you can't give a proper handshake to an individual because the fingers are so deformed, right? So therefore then, once the pain is so severe, then you wind up having to see a doctor to report to the doctor what the pain is and what joint it is, and the doctor is going to take a history. Important. Was there any trauma? Was there any kind of abnormal hemoglobin history that you may have that may be causing the problem? Do you have any history of iron overload disease of one type or another? So on and so forth. There was no trauma. And there's also hereditary, because these diseases are hereditary as well. If your parents have one form of autoimmune disease, you're likely to have either the same or another one as well during lifetime, and so on. So you take a full history, take a work history, very important, the work history, to make sure there was the kind of work the person is doing is crucial. Was there any trauma? Was there any accident? And so on and so forth. You take all that stuff, then you're going to proceed to do a complete examination of the person, because from the skin all the way down to the toe can be affected by rheumatoid arthritis. Take a complete history. Once you take that history, then you're going to proceed to examine the patient. do a complete total examination from the vital sign, listen to the heart, look at the eyes, examine the neurological system, check the abdomen, so on and so forth. Complete exam. Obviously, you're going to take the vital sign and so on and so forth. You do all that stuff. Then your next step, and now you do all that, you're going to start doing some blood tests. Even before you get to do the blood test, you may right away want to do x-ray because the patient's knee is swollen and hurting. You want to address that quickly by sending the patient to the radiology department to get an x-ray of the knee because you want to take a look at what's going on there. Is there a fracture? Is there fluid in there? You could see that on the x-ray. That's crucial. Now that you've done the regular plain x-ray, you proceed to do a complete blood count. Crucial to do a complete blood count. You're going to do a complete blood chemistry profile. You're going to do a urine analysis. Important of all, you're going to do a SETI rate. Very important to do a SETI rate. You're going to do protein electrophoresis. Yes. You're going to do a quantitative hemoglobin electrophoresis. You're going to do that as well. You're going to do serum ferritin. Then you're going to do an A. You're going to do a double-stranded DNA. Then you're going to do a rheumatoid factor. You do your SETI, you do the rheumatoid factor. You get these things out of the way. Very crucial. The first test you're going to look at before all these other more complicated results come in, you're going to look at the SETI rate. The SETI rate is going to be high. Can have an inflammation or an infection in the human body and don't have an elevated SETI rate. Once the SETI rate is elevated, then you already do all these other tests that can cause you to have elevated SETI rate as well. You do all that stuff. Why is it that you're doing a protein electrophoresis? What you're doing, and you also want to do an LDH. The protein electrophoresis, you're going to rule out multiple myeloma because that can cause swelling, it can cause pain. You may want to do a skeletal survey right away. Just do a skeletal survey. If you have elevated SETI rate, you have an abnormal hemoglobin electrophoresis, a skeletal survey is abnormal, and your LDH is elevated. Remember, the LDH is crucial. Again, I've said this and I'll say it again. For every lock that is in existence, there's a key or a code to open that lock, a key or the code. You cannot have any type of hematological malignancy and have a normal LDH. So once your LDH come back as normal, you just rule out at least a dozen different diseases. By that simple test, by doing an LDH, you rule out at least a dozen major diseases right away. You don't have to bother wasting your time throwing money because they're not going to be abnormal. Because you can't, because you have to understand, all these type of cancers grow via the anaerobic pathway without oxygen. And the end product of the anaerobic pathway is lactic dehydrogenase, LDH. So once all these cells, all these abnormal diseases having to do with hematological malignancies grow via the anaerobic pathway. I just wrote a book on the best of medical oncology and clinical hematology. I forget to bring a copy with me. I'll bring it next week. The book just came out. It talks about all this stuff. And I'm just giving you the thing. For those of you who are students, or those of you who are going to take your board, you cannot have a hematological malignancy and have a normal LDH. Because all these malignancies, all these malignant cells, the different types of malignancy, they all grow via the anaerobic pathway. They don't need oxygen to grow. So on the end product of that pathway is lactic dehydrogenase, LDH. So therefore, once your LDH is normal, you rule out so many diseases You don't even bother, okay? Because they're all going to come back normal. That's it. That's it. That's one of the keys you need to know. Another key you need to do, you do a saturate, as I just mentioned. You cannot, there's no way it is possible to have a normal saturate and have a chronic inflammation as well as a chronic infection going on in the body. The few conditions that can cause that to occur, I mentioned last week, if you have no fibrinogen. There is such a disease, but it is so rare because the saturate cannot react without fibrinogen. It's a rare condition. People are born without fibrinogen. So rare, it's not even worth mentioning, but I mention it because to be complete. Other than that, without the fibrinogen, in case you didn't know, which is a phase 2 reacting protein, the saturate will not react. Okay? Will not react. So therefore, if your saturate is, and there is also one more series of diseases, but you would have already done the LDH, but I'll mention it anyway. So you have cold agglutinin diseases. There are several malignancies that are of lymphocytic characteristic, all of them. We call them cold agglutinin diseases. Some of them are malignancies. They manifest themselves as cold agglutinin. So therefore, the saturate, when you put it on the room temperature, it will not react. But you already did the LDH. So therefore, the LDH rule out those possibilities. I'm mentioning it to be complete, okay? Okay? Just to talk that I don't know this stuff, okay? So therefore, once you do the LDH, if you say it reacts, the patient, what's the big deal? Do a serum fibrinogen at the same time. You do a fibrinogen level. We all do. So therefore, the saturate that is elevated is real. It's real. Therefore, you could bet on it. Do what you have to do to look for the inflammatory disease, to look for the chronic infectious disease. You just look for it because it's there. So therefore, then, you do all these tests, and then you're waiting for your result to come back. Those are the general screening for rheumatological diseases. You just send all of them, okay? And if something comes back positive, and you still think the patient have another one of those mixed connective tissue disease, I'll tell you next week how you could bring them into the picture so that you don't miss those diagnoses as well. In the meantime, we are, remember, talking about rheumatoid arthritis. So once we've done all these tests, and next week I will be able to interpret those results for you and then subsequently tell you how to go about treating the patient. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.